Hello, everyone, and welcome to the 19th Annual Community Health Symposium. Before we get started, we just want to apologize for some of the technical issues that we've encountered in the exhibit hall. We want to thank all of our exhibitors for their generosity with their time and just apologize again for that missed opportunity. And before we get started, we just want to announce that we will be offering the opportunity for CME credits for participating in the symposium. So if you are interested, please fill out the form in the evaluation survey that we will provide at the end of the symposium. Again, we just want to emphasize that we encourage everyone to reach out to our exhibitors and connect with them, even if we weren't able to do that successfully at the start of the symposium. They would love to talk to you and let you know about the multitude of opportunities to engage with them.
Thank you so much, Charbel. So to introduce ourselves, my name is Davis Choa.
And I'm Charbel Bukhalir, and we are first-year medical students, the Medical Student Symposium coordinators, and your MCs for this afternoon.
We're so excited to welcome everyone to today's virtual event. Although we truly wish that we could be meeting in person, we will have to make do with the circumstances and look forward to an equally fulfilling afternoon of connection, celebration, and conversations.
In thinking about the past year, we have all gone through so many changes, challenges, and hardships as we've endured this ongoing pandemic. But despite these difficulties, you have all demonstrated an insurmountable amount of resilience as you have all worked together to serve communities most impacted by the pandemic towards our shared vision of health equity.
Since 2002, the Community Health Symposium at Stanford School of Medicine has served to showcase the work of Stanford students, trainees, staff, faculty, and community partners in underserved communities in California and around the world. This symposium is an opportunity to celebrate and elevate the incredible work of our community partners and to foster collaboration, conversation, and idea sharing. This year, we would like to emphasize the theme of engaging communities in health equity research throughout the symposium.
We will start today's symposium with two keynote speakers, Dr. Elise Adams, the Stanford Medicine Innovation Professor and Professor of Epidemiology and Population Health and of Medicine, and Mr. Al Richmond, the Executive Director of Community Campus Partnerships for Health. Each of these keynote speeches will be followed by a 10-minute Q&A. And then after that, we will have 3 concurrent breakout sessions highlighting impactful partnerships addressing current issues related to health equity, climate change, and racial equity. And afterwards, Dr. Bonnie Maldonado will conclude our symposium with a few remarks about the ongoing efforts to vaccinate our communities against COVID-19. And throughout today's virtual event, we'd love for you to take pictures or screenshots and tag us using our hashtags and social media handles that you can find in the chat.
Furthermore, this year, the poster session and presentations were pre-recorded by our community engaged scholars and are viewable on the Community Health Symposium website. We really encourage everyone to take some time to review the presentations and learn more about the great work that has been happening, as well as to reach out to the poster presenters directly with any questions you may have via their contact information on their posters. And before we share further logistical details, we would like to take a moment to dedicate this year's Community Health Symposium in memoriam of Rose Wong. We would like to recognize her legacy as a compassionate colleague, a fiery activist for trans rights, and an incredibly talented musician. 2 Stanford medical students, Chelsea Anebe and Bright Zhao, have shared musical tributes for Rose that we encourage everyone to watch on the symposium website. Please join us for a moment of silence. Thank you, everyone.
Thank you, Davis. And before we get started with our speakers, we would like to present several awards based on abstract nominations to celebrate the incredible work and commitment of staff, faculty, and community partners who make training the next generation of community engaged scholars possible. This year's award for Outstanding Community Partner goes to Roots Community Health Center and Open Source Wellness. So Roots Community Health Center has pioneered the delivery of culturally responsive whole health and championed the integration of navigation, empowerment, social enterprise, nutritional, pediatric, legal, and mobile health services to address the myriad needs of over 10,000 patients in our community. And to quote one of our student nominees, open source wellness and their staff, quote, are also caring for the surrounding community as well as supportive of student mentorship and have implemented incredibly innovative methods to reach out to underserved populations, end quote. So please join us in celebrating Roots Community Health Center, as well as open source wellness for their incredible dedication and commitment to supporting underserved communities.
Our second set of awards are the Outstanding Faculty Awards. And this year, the awards go to Dr. Jennifer Newberry and Dr. Jonathan Shaw. So to quote one of the student nominations, Dr. Jennifer Newberry's mentorship, compassion, and willingness to help her students through any challenge, no matter the time or demands on her in a pandemic particularly, are unparalleled. Likewise, quote, Dr. Jonathan Shaw has demonstrated incredible passion about addressing social determinants of health through his work with underserved populations and particularly homeless veterans. We would like to congratulate Dr. Newberry and Dr. Shaw for your commitment to community engagement, as well as celebrate and thank you for being trailblazers and your commitment to mentoring students. Thank you.
And last but not least, the biannual Rhonda McClinton Brown Community Engaged Leader Award goes to Dr. Tia Rich and Dr. Janine Bruce. And again, based on student codes, Dr. Yarich, according to her students, was instrumental in guiding students and the community partners through an evaluation process that was aligned with the unusual circumstances that they faced over the past year with COVID. And Dr. Janine Bruce provided invaluable mentorship each step of the project and truly embodied the ethos of community-centered work. So please join us in congratulating Dr. Rich and Dr. Bruce on their dedication to community engagement and to supporting students in unusual circumstances.
Great. Thank you, everyone. Let's all congratulate our 2021 awardees once again. Feel free to send some emojis, reactions, send some congratulatory words through the chat. Thank you all so much for everything that you've done and continue to do to support our communities and advance health equity.
And now we would like to introduce Dean Lloyd Minor to provide us with some opening remarks.
Well, thank you very much, Charbel and Davis. Thank you so much for all the work you've done to organize this symposium today. And also special thanks to the Office of Faculty Development and Diversity and the Office of Community Engagement for their work in organizing this symposium. The 19th Community Health Symposium as a part of Stanford Medicine, that's a true milestone. And never has the importance and the need of activities related to community health been more evident and more clear than it has been during this past year, where we've all suffered and endured and encountered the devastating effects of COVID-19. We know that the effects of COVID-19 have highlighted the disparities and inequities that exist in our society. And you're all familiar with the data. Black communities, Latinx communities, Native American communities, the likelihood of death in people who contract COVID-19 is roughly twofold higher than in white communities. Black women who are pregnant are more than threefold likely to have serious complications from COVID-19 than are white women. And the list of disparities goes on. And it really serves to highlight the social, behavioral, and environmental determinants of health that are so important, but are so often missed or ignored. Even before COVID, there was the stark statistic that in the District of Columbia, relatively small geographic area, there's an over 30-fold difference in life expectancy between two different neighborhoods in the District of Columbia. Those neighborhoods differ in terms of the demographics of their residents and also in terms of socioeconomic factors. The time has never been more important for us to address the social, behavioral, and environmental factors that are involved in health, and also to acknowledge that just as in so many other aspects of our society and our country, systemic racism plays a pernicious part in determining health outcomes. And addressing systemic racism has to be also one of our goals as healthcare professionals and as an academic medical center. The challenges are daunting, but also I think the capacity and the ability and the dedication of people within Stanford Medicine to address these challenges and to have real impact is palpable. We've seen it during the pandemic, how people from all aspects of Stanford Medicine have stepped up to have impact in real ways, both with engagement of the communities, with what we've done in rolling out our testing programs to underserved communities, and now with our establishment of a vaccination site in East San Jose, partnering with the county of Santa Clara and the public health department to deliver vaccines to an underserved and in an area that's where COVID is highly prevalent in San Jose. There's still a lot more that we can, we should, and we want to do to address the disparities that exist just within our own area, and through what we do as a leading academic institution through our research and our training programs to have impact much broader than the Bay Area demographic that we directly provide healthcare to. There's a lot to be done, and it's through activities like this, it's through this symposium, through the many other activities that are being organized through your groups, that we're able to have the type of impact that we know we can and should have. Also, I want to mention that after the horrific murder of George Floyd last year, we came together as leaders. Paul King, the president and CEO of Stanford Children's Health, David Entwistle, the president and CEO of Stanford Healthcare, and myself came together to say enough is enough. We want to have impact on the topics and issues of systemic racism in our society, beginning by first examining who we are and where we are today in Stanford Medicine, and then by really serving as a beacon where the programs, the activities that we do here, that we initiate and carry out here to address systemic racism, that those can be a model for other communities in our country and around the world. We commissioned a group on justice and equity, a commission that just recently finished its work interviewing a large swath of our community to understand where we are today and to give us as leaders and in our entire community feedback on where we can and should be headed in the future. This commission has recently finished its work and will be delivering its report to our community in the near future. I think we share a common set of values here, a common mission and a common drive. And that in so many ways has been what has sustained me during these past tumultuous months of COVID-19. The knowledge that we want to have impact through the care we deliver to our patients, the people who entrust their health and well-being to us, through the research we do, and through the people who come here to train and learn how to have impact in the world once they leave us to move on to other organizations and other positions. I think crises can bring out the best in organizations, or they can bring out the worst in organizations. And I think all of us have a lot to be proud of in terms of how we as an organization, Stanford Medicine and Stanford University, have come together during the many crises that came upon us because of COVID-19, how we've come together to take care of ourselves and to take care of those who entrust their care and well-being to us. Thank you so much for joining today. Thank you to the organizers for putting together this almost 2 decades now of symposia in clinical health and community health. It's been my privilege to participate in most of these in the past, and it's a real privilege and honor to be here with you today. I hope that next year when we convene for the 20th Symposium in Community Health, that we'll be doing it in person as we have done on so many occasions in the past. Thank you.
Thank you so much, Dean Miner, for those opening remarks and really inspirational words to help us kick off the symposium. We really appreciate your leadership and support as we continue to all work towards a healthier and more equitable world.
Thank you, Dean Miner. And now we would like to introduce Dr. Lisa Goldman-Rosas, who will introduce our keynote speakers for this afternoon. Dr. Goldman-Rosas is an assistant professor in the Department of Epidemiology and Population Health, as well as assistant professor of medicine in the Division of Primary Care and Population Health at Stanford School of Medicine, as well as the faculty director of the Office of Community Engagement.
Thanks so much, Davis. Thanks so much, Charbel. Oh, here we go. Thanks so much, Davis. Thanks so much, Charbel. And thank you so much, Dean Miner, for that wonderful opening remark to really set us off. I too share the hope that in our 20th annual symposium, we will be all together in person. So it is my distinct pleasure this afternoon to get to introduce our two keynote speakers. We're so lucky to get to have two keynote speakers tonight. So I will, or this afternoon, I'll introduce both. They'll give their talks and then we'll open it up for some Q&A. So I want to make sure you make a liberal use of that chat function and submit your questions as the keynote speakers are speaking. We'll be monitoring the chat and then we'll be facilitating the Q&A at the conclusion. Great. So let's begin by introducing our first speaker, Dr. Elise Adams. So Dr. Adams is one of the most recent additions to our faculty. And actually, she just said the other day that she's been here just 8 weeks. In this short time, I've admired how she's effortlessly integrated into our various communities here at Stanford. I've been inspired by her new and exciting ideas and felt incredibly grateful to have such a wonderful colleague. So Dr. Adams is the Stanford Medicine Innovation Professor and a professor in the Department of Epidemiology and Population Health and in medicine in the Patient-Centered Outcomes Research Division. She also serves as the Associate Director for Community Outreach and Engagement in the Stanford Cancer Institute. Dr. Adams' stakeholder engaged research seeks to identify and address modifiable determinants of disparities in chronic disease treatment outcomes. Prior to coming here to Stanford School of Medicine, Dr. Adams was Associate Director of Healthcare Delivery and Policy and a research scientist at Kaiser Permanente Division of Research, as well as a professor in their School of Medicine. She also serves as the Vice Chair and Board of Directors for Academy Health. Dr. Adams received her PhD in Health Policy and a Master's in Public Policy and Social Policy from Harvard University. And finally, we're lucky she's not on jury duty and here with us in person. So without further delay, Elise, take it away.
Thank you so much. I really appreciate that. And my apologies, my video is a little wonky today. So if you see sort of this Cheshire cat imagery, my apologies. I'm going to go ahead and share my screen and talk with you today about why I think community engagement really is one of the key pillars to advancing health equity research in the future. Essentially, as Lisa mentioned, I am a health services and policy researcher. So a lot of my work really focuses on identifying specific types of challenges that we face both in healthcare and sort of more broadly in terms of public policy with respect to health disparities, and then trying to apply scientific methods to address those problems. In terms of, for starters, I just want to really thank everyone for allowing me to speak today. This is such an honor. And I want to thank the Ohlone people and other Indigenous peoples who are the caretakers of this land for our use of the land and for your partnership. So today I'm going to talk about some key concepts in health equity research. Many of you will be familiar with these. And so I hope in the chat you'll be challenging me as well in terms of how we can push the envelope with respect to health equity research. I'll share some key lessons that I've learned over the last 20 years as a health services and policy researcher, really focused on trying to understand and address disparities in chronic disease treatment outcomes such as cancer, diabetes, hypertension. And then I'll talk about why I think stakeholder engagement is such an important catalyst to addressing gaps in research impact. First, many of you have seen this or some version of it in terms of one of the drivers of health inequities. And they include both what I would say sort of structural determinants and social determinants of health, as well as sort of the intermediary. And I like the way that Solar and colleagues put this together in terms of their conceptualization of the disparities conundrum. And so on the left-hand side, you see things that are sort of more structural, things like policies and governance, structural racism, social class, culture and values, things that are sort of a part of the rubric in which we work and live. And then on the right-hand side, you see things that are really sort of more individualistic and related to healthcare systems, including material circumstances, our own behavior, biology, psychosocial factors, as well as the healthcare system. And I think what's important to note and why I like this particular graphic is it shows that these things are always moving and changing and interacting. And it's these movements and changes and interactions that both produce disparities, but also give us hope for our ability to make changes, to find those modifiable factors that we can move and we can shift in large ways through policy, but also in smaller ways at the healthcare system that have the potential to really get us to where we want to be in terms of being a more equitable society with respect to health outcomes.
Dr. Adams?
Yes.
I'm so sorry to interrupt, but we're currently seeing your presentation in presenter view. If you could click display settings at the top.
My apologies, let me see. And
swap, yes.
Did that work? Okay,
yes.
Perfect. That's
thank
very
you
strange.
So much.
Okay, thank you. No, thank you. So again, so structural determinants in terms of chronic disease treatment disparities, which is where a lot of my research really focuses on a couple of different areas. One is sort of coverage of clinically effective medications, cost containment strategies and state Medicaid programs, for example, to contain costs, often have sort of what we call blunt instrument policies that are designed to restrain costs related to prescription drugs, but actually often disproportionately hurt people of color. There are also other issues related to ease of access in terms of things like prior authorization, which make it harder for physicians to prescribe, with the idea towards having us do better, sort of more evidence-based prescribing, but often these actually result in unintended consequences. I've also looked at intermediary determinants related to quality of care and prescribing within healthcare systems, as well as ease of access and affordability for individual patients. So many of you have seen this before, but this idea that equal access is not enough, but it's necessary, but not enough to address disparities. And the reason is that giving everyone the same thing isn't going to solve the problem. Not only because everyone's not the same, but because the ground that we stand on is uneven in a lot of ways. And if you think of those structural determinants of health. And so in order to really sort of address these issues, we have to both think about these intermediary as well as these sort of structural factors. And so a lot of the work that I've worked on, for example, looks at expanding health insurance coverage. To what extent can that reduce or eliminate gaps in the use of clinically effective therapies? And so one question is sort of why study this area? One is that in terms of non-adherence to chronic disease, the treatment costs are estimated to be about $100 to $300 billion per year in the United States alone. So non-adherence alone contributes that much. And disparities by race and ethnicity are prevalent in non-adherence, and the reasons for non-adherence are multidimensional. Eliminating those disparities, however, it's been estimated that in asthma alone, if only we could improve adherence, for example, among Blacks with respect to use of preventive asthma medications, it's estimated that we could save $16 million per year. So even if you don't believe the ethical argument, there is actually a direct cost impact of not addressing these disparities. So policy level interventions are wonderful tool for disparities reduction in that they have greater potential for impact across large numbers of people at the population level. They are often sustainable. Once you put a policy into place, it's actually hard to rescind it. And they can also be scalable. So you can test something out at a local level and then see if you can expand that to state and as well as a national level. And frequently that happens in policy. They can also be evaluated using rigorous designs. And what you see on the right-hand side is an interrupted time series design, something we use quite a bit in our work, in which if you want to compare it to what's going to happen to two different groups when there's a policy change, what's nice about interrupted time series is very simply it asks what would have happened had not the policy taken place. And basically you look to see the past, what happens in the past, what's going on in terms of trends in the past, in terms of the gap. And then you project out, which is the dashed line, about what would have happened. And then we observe to see what actually happened. And then we use statistics to actually estimate to what extent did the policy over and above what normally would have happened change how people utilize these medications. The challenge here with these policies is while they often have an immediate impact on utilization of medications, for example, they can also have unintended consequences in that they're often, like I said, blunt instruments, and it's very hard to sort of tailor the policy in ways that affect different populations. So just as a quick example, this is an example where we looked at Medicare Part D and the impact of Medicare Part D, which provided prescription drug coverage to dual enrollees, people with both Medicaid and Medicare coverage who previously had restrictive Medicaid drug coverage. And what we found in cancer, for example, this is the dark line is the gap. So we looked at gaps between Blacks and whites in terms of utilization of antidepressants among people who were cancer survivors and had concurrent depression. And we actually saw over time, before the policy went into place, which is the shaded bar, that we actually see an increase in that disparity over time. What happened after the policy went into place is actually the disparity reduced because both Blacks and whites were more likely to use these medications, and Blacks in particular were more likely to use medications who had not done so previously. So we actually saw a diminishing of the gap in that case. However, when we looked at diabetes, we saw the gap widen. And so in this case, the gap that you just saw is a dashed line in this case, where we actually saw a steady gap in antidepressant use among diabetes patients, for example, people with diabetes prior to Medicare Part D. And what happened with Medicare Part D is that while everyone increased their utilization somewhat, the gap actually increased over time because of a difference in response to the policy among different groups. And so there are lots of reasons why this happens, theoretical and otherwise. We call it sort of the inverse equity hypothesis. We call it a number of different things. But the bottom line is often when you make something available, a new innovation, a new policy, a new coverage available to the population, those who are closest to the healthcare system already, those who are already somehow engaged in with government, have an understanding of their coverage, are more likely to take advantage of it immediately. Those people who have more barriers to that, often there's a widening of the gap for those groups, at least initially with respect to the policy. And so this extends again beyond coverage policy. It also affects technological innovations and other care innovations in healthcare. So we might want to worry about simply turning on the spigot and hoping that people will arrive and take advantage. We really have to think strategically about how do we make sure that the groups that we're most concerned about can actually take advantage of these innovations. Another thing that we've learned is that one size did not fit all. And this is particularly true when we look at quality improvement with respect to disparities. And in particular, when I was first starting out as a PhD graduate, one of the things we were asking was, can moving everybody into managed care, for example, from Medicaid, reduce or even eliminate gaps and disparities? Because not only do they have access to care, but they have access to relatively higher quality care than they may have in fee-for-service settings. And so what we found was that, yes, by moving people into a system that has population management approaches, which really sort of it's like an engine that works to make sure that people are aware that they have tests due, that lots of things are automated instead of leaving it up to the physician to remember, the nurse case manager to remember, you put it into the electronic health record and everyone's sort of behind and part of this system that really sort of brings patients in and has a process for bringing them through and making sure that they get the right care. And it's always evidence-based. The challenge here is that while it does improve the rates at which people get tested, the likelihood that they get a prescription, the likelihood that they get their annual exam, it has less effect on behavior and outcomes, such as adherence and outcomes. And on the right-hand side, this basically just shows that with respect to diabetes patients, we looked at 6 and 12 months prior or after following their first diagnosis of diabetes, we already saw the disparity in medication adherence right when they were first diagnosed. And that persisted over time, even though we didn't see disparities in some other things that we might care about, such as dose augmentation by physicians or access to lab tests. Similarly, when we looked at cholesterol testing and diabetes, people who have diabetes, we found the same thing. Again, cholesterol testing, more likely to test, but less likely to be in control. Excuse me. So we also looked at this in terms of hypertension in another setting, where we looked to see sort of what factors are in play? What might we do to address disparities? And certainly we found things like medication copay, mail order pharmacy, type of prescription that you received, those all contributed to non-adherence and disparities in adherence. And in fact, you have the potential to reduce those disparities by addressing things like higher copays. However, the disparity didn't go away. It was reduced, but it wasn't eliminated from most people. So there's this persistent difference that we couldn't address using sort of population level management strategies alone. So what does it mean for interventions to address disparities in chronic disease treatment and control? Well, Bauman and colleagues looked at this as an implementation science type of challenge, specifically that we need to focus on reach, finding those diverse patients, not just sort of building it and hoping they'll come, but rather finding them, enrolling them, and engaging them in the process. They talked about designing and selecting interventions with implementation in mind. So it wasn't enough to say, well, again, we'll turn it on and see who shows up. You rather think about what are the pathways for people to be able to access and fully utilize these innovations in care. And stakeholder engagement was, again, a big part of that. We also talked about implementing what works and develop implementation strategies that can reduce inequities in care. So really sort of have an eye towards evidence-based interventions that have known ability to address disparities. Again, I talked before about this issue with respect to chronic disease treatment outcomes and why treatment and adherence were so important. And that was because we knew it was one of the drivers of disparities in control and equities in control. He also talked about the development of scientific adaptations, sort of finding new ways to look at doing science to address the needs of the community, and also always having this equity lens on. So it's not enough to say, oh, well, there's an issue with the cost of care, so we'll make the cost of care less. You have to think about what are the other barriers in addition to costs that prevent people from taking advantage of expansions in coverage. And so again, just from Mata and Davis, they talk about this sort of the way to get engagement in research is to engage stakeholders throughout the entire process, from the identification of the problem all the way through to implementation. And through this iterative, ongoing relationship building and process, we're more likely to get results from our research that actually have an impact on patients rather than designing things in isolation and hoping that they work with specific populations. So some of the specific advantages, again, are sort of overcoming some consistent barriers in terms of understanding individual preferences and values. How else can you understand individual preferences and values unless you ask people, right, in terms of motivations for behavior change? Broadening the dissemination of our research findings. So not just talking to each other as researchers, but talking to communities, talking to policymakers, getting the word out about our research so that we can better understand how to interpret the findings and that they can also gain from the knowledge that we learn. Informing system and policy level interventions is another option for us as investigators to get involved. So not just involving stakeholders or stakeholders in terms of communities, but also involving stakeholders in terms of health systems leaders and people who are involved in setting policies that have the potential to affect these populations. And what about the science? Really, I think engaging stakeholders enhances our ability to understand the mechanisms of action in real world settings, right? So not just when we can control the experiment, but rather when the experiment's all around us, right? And that's the exciting part of being a scientist in this field and being able to engage with stakeholders to understand the world around us, to understand sort of real world interventions and work with them to understand those impacts and how we might improve the impact on patient populations. Engaging stakeholders also increases the generalizability of our findings. It forces us to think about things like eligibility criteria, for example, for clinical trials and whether or not we're involving the people who actually are affected by the research. It also allows us to look at things like likelihood of uptake. If we build it, will they come, right? The chances that they come will be heightened if the communities that we're trying to reach have a vested interest and a vested participation in the building of those innovations. And finally, I'm hoping that what we can get to is a reduction in the investment in low yield interventions. So rather than continuing to intervene in ways that aren't particularly successful with these communities, perhaps involving communities in the development of those interventions will actually be more efficient for us as well, because we'll spend less time on interventions that simply don't yield results. So in terms of some of the work that we've done in this area to involve stakeholders, we did a study called the Diabetes Telephone Intervention. It was a cluster randomized controlled trial, which basically meant that we randomized physicians instead of individual patients. So we randomized the physicians and then anyone in their panel might be eligible for the trial. And we focus on peripheral neuropathy treatment because it was something that our people with diabetes told us about as being a real problem for them that affected the quality of life and that it was hard to talk to their physicians about, that didn't seem to get a lot of attention when they went to their physician visits. And so we worked with them to develop an intervention. And some of the specific ways in which they informed that intervention were to help us to isolate the impact of the intervention. So we talked with the patient partners and they helped us to co-create educational calls that were sort of this active control arm. So our intervention was through the telephone, and we knew in order to be able to understand the impact of that we needed sort of a counter situation in which we could evaluate what would happen if they got a phone call, but it was purely educational versus if they had a phone call that was interactive. And so the patients actually helped us to not only develop the idea of that active call, but to actually decide the content of that call and the direct messaging in those calls about risks. And I will say one of the interesting things were the physicians in the room were very reticent to talk to in the educational calls about the consequences of diabetes and the consequences of not taking care of your feet, such as lower extremity amputation. Our patients said, you can't hide that from us. It's a risk, and it's a real risk for us. So to not tell us is not the way to go. The way to do it is to have a conversation with us. We need to know these things. You're not going to scare us, but you might help us to better understand the connections between things like our glycemic control and the risk of lower extremity amputation. We also looked at things like physician overload. So this was an alert system where we alerted physicians in the electronic health record once the completed call was done with the patients. And the clinicians helped us identify which criteria to implement such that the alert was actually active versus something that would just sort of passively go into the electronic health record. In particular, they were thinking about those things that the patient triggers that the patient might see in the call that would then prompt them to action. And so we were able to develop that by involving clinicians in the actual development of the alert. Finally, we also looked at tailoring the intervention to the specific patient population. Because these were phone calls, we were also aware that some people may have issues with automated calls. And so these were older patients who helped us to think through things like hearing limitations and other factors that might influence the ability of the patients to get to the phone call. One of the first things they told us was that the actor who did the voiceover for the calls needed to slow down, that she spoke way too fast and that she needed to slow down for the patients. And so they really helped us to craft a messaging system and a process that really worked for the patients. So a lot of what we're doing at the Stanford Cancer Institute, at Stanford Medicine, and elsewhere are really to build infrastructures for patient, community, and stakeholder engaged research. The really goal here is to address these inequities by engaging those who are affected by the inequities in the research itself. And just some examples are the Aging Initiative. So I'm lucky enough to be a multiple PI on something called the Aging Initiative, which really is, it's a group of Pepper centers, which are basically academic centers looking at geriatric care and research, as well as the Healthcare Systems Research Network, which are basically managed care organizations that care about these issues. And we've been able to develop a really robust patient and caregiver advisory group who work with us very, very closely on everything from designing webinars for early stage investigators on how to create successful partnerships, to being partners in the review process for pilot proposals, as well as for applicants for our scholars program. They also co-develop projects with our scholars, and they're serving as senior advisors to the project to develop a roadmap currently in the development of a clinical trials network for COVID-related research that was a direct ask from the National Institutes on Aging. So very active group, incredibly robust, and they're always pushing us to push the envelope in the ways in which they can inform the work that we do and to really create an infrastructure that makes these partnerships easier. Of course, we have our own SCI, Cancer Health Equity and Community Engagement Group. I'm lucky enough to co-lead this with Lisa Goldman-Rosas. Our mission really is to reduce the overall cancer burden and cancer disparities in our catchment area and beyond through research, education, community outreach, and engagement. We're super excited to be at this stage of the work where we're really thinking about how to build this, how to create something that has the potential to really provide that critical glue between the research world and our communities, such that we can really start to engage in meaningful ways with patients in our research, not just for those who are sort of inclined to do so, but making it easier for all of us to engage stakeholders in order to have real impact. And so this is our catchment area. And so it really does show you the areas that we're focused on in terms of the East Bay, San Joaquin Valley, Peninsula, South Bay, and Salinas Valley. And just in terms of concluding thoughts, I just wanted to say, again, through our research, we know that access is necessary, but not enough to address these persistent disparities and inequities in care and outcomes, and that a proven quality of care alone is not enough, that we have been less successful in addressing disparities in things like behavior related to treatment adherence, for example, and specific chronic disease outcomes. And that really does require this sort of stakeholder engagement piece, that it's a critical catalyst for speeding the translation of research evidence, as well as innovation into action in the healthcare system, the community, and at the policy level. So thank you so much, the Office of Community Engagement and Office of Faculty Development and Diversity, and everyone who put together this particular talk. And I'm so happy to take questions.
Elise, thank you so much for such a wonderful talk. I wish you could hear immense applause in a large room. For now, you'll have to deal with my emoji applause.
No, I appreciate it. Thank you.
Thank you so much. I think you did such a wonderful job describing structural determinants of health disparities that we observe, showing some concrete evidence. And I really appreciated the really specific ways in which you highlighted stakeholder engagement throughout your research. It was really, really wonderful. Thank you so much.
Thanks so much.
So we're going to go ahead and take questions after Al Richmond's keynote. So that means for everybody who has been inspired by Elise's talk, I would like you to put some questions in the chat box, and we'll be saving those. I don't want you to lose those great ideas, and I'm sure you were provoked by her talk. Okay. So we are honored to have our second keynote speaker, Al Richmond. He is the Executive Director of Community Campus Partnerships for Health, and we are so glad that you are here with us this afternoon. I suppose for you it is evening, although it is still afternoon here on the West Coast. For those of you who are not familiar with Community Campus Partnerships for Health, I encourage you to go check them out on the web, of course, after tonight. And get familiar with them. They're known as CCPH, Community Campus Partnership for Health. They are a global thought leader advocating for the increased role of communities in research and public health. So a lot of what Elise was demonstrating in her talk. You'll notice today in our program in the breakout rooms that all of our panelists are accompanied by their community partners for our presentations as a reflection of our dedication to community partnerships here at Stanford. So Mr. Richmond is truly one of the foremost leaders in community engaged research nationally, globally, and we're so lucky to have him. He serves as a principal investigator on several PCORI and NIH and other funded projects to advance the science of community engagement. He's written the guidelines for the conduct of community engaged research. So he's literally written the book on what we're doing. He serves as a founding member and past chair of the Community-Based Public Health Caucus and the National Community-Based Organization Network. He helped to foster effective partnerships focused on community-identified health concerns and partnerships that integrated local leaders in the decision-making process. So I could keep going about all the wonderful credentials and accomplishments, but he specifically asked me to keep it brief, and I'm a rule follower. So I am going to turn it over to you, Mr. Richmond, and I hope all of our attendees will join me in welcoming you here to our Stanford community.
Thank you so much. Good afternoon or good evening. I'm going to actually share my screen, and because after hearing the presentation, I thought, you know what, I need to step my game up, and so I've added some slides and appreciate that. Can you see my, hopefully you can see my.
We can see them.
Okay, good. Thank you. I want to say, Lisa, thank you. That is such a warm welcome. I absolutely appreciate it. I want to acknowledge Davis and Charbel. Thank you for co-facilitating this afternoon, and also to Dean Miner. Thank you for your opening comments. I had to turn on a little bit of extra light here. It's getting late on the East Coast. I'm so excited to be with you at Stanford. I was thinking as the webinar was starting that how this means so much to me. I, for a number of years, had talked about the opportunity to partner more in-depthly with Stanford, in particular, one of our former board members, Rhonda McClinton Brown, who worked in engagement at Stanford. And we had just talked about the opportunities, and now she is working at the county health department, and I'm excited about that. The other point I want to acknowledge is that it was back in January of last year that I visited the Bay Area, and Rhonda took me on a whirlwind tour of Stanford's campus. And I had always wanted to see that living on, when you're kind of bi-coastal in some ways, where you're living on the East Coast, when you visit the West Coast, you absolutely want the opportunity to visit all of these amazing places. And certainly the campus of Stanford is one of those places, and serves to accentuate the Bay Area. So, and looking back to 2020, I'm so glad that I spent more time in the Bay Area and had the opportunity to visit Stanford's campus. I had little idea or could even project that shortly thereafter, we would actually kind of engage in this national lockdown almost, and I would not have the opportunity to travel for over a year. And so I'm really glad that I made the opportunity and took the time to visit your beautiful campus. I want to acknowledge Dr. Adams and her amazing comments. I had to tweak my presentation a little bit based on what she said, but it was, I think, very complimentary of what I want to share with you this afternoon. And thinking about a theme this afternoon, I want to focus on building a network for authentic engagement and share with you not only the work of Community Campus Partnerships for Health, or CCPH, but also provide some examples of how we are actually advancing what I consider equity and even justice at this moment in time. So want to start by talking a little bit about what our mission is as an organization. And again, as Lisa mentioned, you can find out more about CCPH by visiting our website at ccphealth.org. Our mission is to promote health equity and social justice through partnerships between the community and academic institutions. And, you know, what I say to people is that we're living out the principles of partnership all the time. It's just absolutely so important to us as an organization. And issues around health equity, which Dr. Adams talked about, and social justice at this moment have really become centered and critical to all of our conversation and really global dialogue. When we think about partnerships, it's not just about those partnerships between the community and academic institutions, but also include anchor institutions as well. Because when we think about anchor institutions, we realize that in many communities, urban and rural, they may not have an academic institution, but they're the anchor to that community. It may be a volunteer fire department, it may be a hospital, it may be a small businesses, it may be faith-based organizations. So I believe that the principles that we talk about in our organization in terms of authentic partnerships are applicable in many different types of partnerships and collaborations. We believe that authentic partnerships facilitate social justice and health equity. For me, racism and inequity, unfortunately, is baked into the system, such that, you know, as I've been doing this work with CCPH for the past 8 years, I've come to understand that when we have, you know, partnerships that are not equitable, that are not just, then the outcomes will not be equitable and they will not be just. So we have to start kind of upstream, looking at the structure, the nature of the partnership itself, such that we think about it for CCPHs, how are decisions made, the governance of that organization or that partnership. So all of this is really important to us, and I'll define authentic partnerships a little later on, but again, that's what we really believe. And quite frankly, you know, me, I absolutely believe this. And I believe that what we're seeing manifested today through policing, through healthcare, and all of that is because we have inequitable systems. And these systems just kind of breed after themselves. You know, for a long time, I really thought that racism was about individual acts of microaggressions, one-on-one types of experiences. But racism is really about the institutional, the systemic nature of racism. And when people say that systems have failed, I say, no, systems haven't failed. Systems do exactly what systems were created to do. So when you have inequitable systems that have been created, they just breed that. And so it's no wonder that we are kind of, at this moment, having this global reckoning with racism. It's because we've not, you know, actually addressed it in the way that we should. I wanted to give you at least 3 examples of the work that Community Campus Partnerships for Health is engaged in around equity in this moment. of COVID-19. I'll lift up two of those examples. Many of you may be familiar with this one, and this is the RADx Up project, which is the Rapid Accelerating Diagnostics for Underserved Populations project. NIH, at the height of COVID-19, stood up at least 4 RADx projects to respond rapidly to the onset of COVID-19 in the US. One of those projects was the RADx Up project. This project really is working with 69 testing projects throughout the United States to really better understand the uptake of COVID-19 testing, the diverse populations across the United States. This project was launched last year, and CCPH is excited to be part of the work of RADx Up. We actually co-lead the Community Engagement Core. Our job is to help to ensure that communities are engaged in this work. There's equity and there's actually justice that is achieved through these projects. Sorry, pollen is up on it's pollen season, sorry. So RADx Up, but I guess in California, you don't think about these different seasons, but here it's really pronounced. And so RADx Up is a network of 69 projects throughout the US, and these are the list of these projects across the United States, working in diverse populations to really address COVID-19, the testing, and certainly we are moving towards issues around the vaccine uptake as well. This map will grow and we'll be adding at least 100 additional projects in the next quarter to this already amazing network of projects across the US focused on COVID-19. The other project that we're working on and glad to be a part of is the SEAL project, which is also an NIH initiative around, this stands for Community Engagement Alliance. And NIH has supported COVID-19 activities in 11 states. These were states that had among the highest incidents of COVID-19 in terms of incidents and also deaths and mortality from COVID-19. North Carolina, where CCPH is based and where I live, was selected as one of those 11 states. We have stood up a project here in North Carolina, which is called the I-Team Project, and that stands for Increasing Trustworthiness Through Engaged Action and Mobilization. This is a partnership between Wake Forest School of Medicine, the Maya Angelou Center for Health Equity, the UNC School of Medicine Center for Health Equity Research, and also Community Campus Partnerships for Health. In this project, we are working in 3 communities across the state of North Carolina: African American, Latinx, and American Indian. We have established what we call community response teams, or CRTs. These community response teams are working closely with community-based organizations, faith-based organizations, and other partners to address questions and issues around COVID-19 testing, more recently around vaccine hesitancy. And I think we're doing an amazing job with our partners across the state of North Carolina to really increase access to COVID-19 testing, to address issues and concerns that many communities have regarding the vaccine as well. We have sponsored a series of webinars addressing a range of issues associated with COVID-19. More recently, we focused on COVID-19 therapeutics. Our intent is to increase an understanding of the continuum of services that are available to residents of North Carolina around COVID-19. Again, this project is in 11 states. It is growing also to some urban cities. And unfortunately, many of the states that were selected are in the South and the Deep South, where large numbers of African Americans have already died from COVID-19. So this is a project that has a tremendous degree of urgency for me personally, but also for our response team members. And I think that the community response teams are almost like a rapid deployment of community leaders to help us at this moment. And I think this really does represent in some ways a best practice in how we address inequities. Because if we think about it in terms of the urgency of it, then we would become more serious and more intentional about our work around addressing health inequities and not kind of see them as laissez-faire and, even trying, seeing them or marginalizing them or minimizing them. The third project that I want to lift up, that we're doing and we're engaged in to address inequities is another project that's funded by the Patient-Centered Outcomes Research Institute, PCORI. And this project is called the At the Heart of the Matter project. And we're building a framework for collective action. This is a partnership between Community Campus Partnerships for Health, the American Heart Association, Morehouse School of Medicine, and other partners. And we're working with historically Black colleges and universities that we call HBCUs. The Southeast region where I live has among the highest concentration of historically Black colleges and universities in the United States. So we're working in a 7-state region to bring faculty, staff, students, and their community partners together to address issues around cardiovascular disease. We have pivoted our focus to also include COVID-19, such that on April 15th, 16th, and 17th, we'll convene over 200 leaders from the region and our historically Black colleges and universities to help us really better understand what are those issues on the ground that are critically important to communities, again, focused on cardiovascular disease and COVID-19. And we believe that this is among the first that we're aware of efforts to really bring this really critical group of leaders together and stakeholders to address and develop an agenda around cardiovascular disease. So I want to talk a little bit about health equity, and Dr. Adams talked about this, and just in terms of just making sure that we frame this, that health equity is the assurance of the conditions for optimal health for all people. And Dr. Kamara Jones really makes this point so poignant that there are critical elements or drivers that are needed around this whole issue around health equity. And first of all, is to value all individuals and populations equally. And we know that we've not done that as a country. We absolutely have not done that. In fact, we failed abysmally. And so our hierarchy around individuals and the value and worth of individuals based on their physical manifestations and all of that is just absolutely crazy, right? And so we have to value all individuals and populations equally. We have to recognize and rectify historical injustices. It's one thing to say it's bad. It's one thing to feel sorry. It's totally different to actually begin to do the hard work of rectifying those historical injustices. So it's about not just talking the talk, but walking it and making sure that you're living it out. And it's being intentional about addressing those historical injustices that continue to persist in our society. It's also to provide resources according to need, which is around equity, not equality, but equity. And then it requires a fundamental shift and how we think about those at the margins. And so when people talk about this idea of underserved populations and people at the margins and populations at the margins, I am prompted to ask the question, who marginalized these people? Why are they at the margins, right? They didn't just gravitate towards the margins. They have been forced out and excluded from being centered in this work, such that Dr. Jones says that health disparities will be eliminated when health equity is achieved. So we really have to work towards addressing and achieving health equity. This slide is similar to the one that Dr. Adams shared with you, that looks at equality, the difference between equality and equity. This is another way visually to really kind of drive the point home. I would ask that you would focus your attention to the lower side, end of the screen, wherein you look at equality. And this is an image where everyone has a bicycle, right? So when we think about equality, it's about providing everybody with a bicycle, right? Everyone has a bicycle for you, one for you, everyone gets one, right? It's like the Oprah Winfrey Show. But equity is really about providing people what they need, right? Such that we're not just providing everybody with the same thing, but it's actually taking into consideration what people need. That's equity. And so when I talked about resources, equity is not giving everyone the same amount, but based on their need, what do they need to shore that up? And it takes into consideration the historical injustices that have occurred. When we look at home ownership, when we look at redlining in this country, we see that the difference between the wealth gap between Blacks and whites in this country is also because of historic redlining. There's a reason why that has occurred in this country, and there's a reason why we continue to see this wealth gap, this persistent wealth gap that's only been made worsened by COVID-19. So again, this idea of health equity is around, addressing the disparities. And then when we address the disparities, we can achieve health equity. A lot has been said about social determinants of health. A lot of people are focused on it. I would say that the social determinants of health are not discrete services. Oftentimes people think about food or housing or similar services, and they think of those as social determinants. They're really more systemic in nature, but they're also the conditions in which people are born, grow, live, work, and age, including the health system itself. It's about the distribution of money, power, and resources at a global level. We oftentimes think about money, but it's also about power. And so we have to recognize that all of that contributes to that. The ability of people to even advance policy change. It's about power. When we look at what's occurring in Georgia at this very moment, and is occurring in other states, in particular southern states, as a southerner, where these things are egregious, right? And it's the people exerting power and controlling the ballot itself. And that power will drive further inequities. And so we have to think about that. So, our work around social determinants of health has to really address the power imbalance and inequities that we see, and such that the social determinants of health are mostly responsible for health inequities. And I like this slide. And the reason why is because we focus a lot on health behaviors. We've done that for years and years. I worked in a health department, and the health departments are good with focusing on health behaviors, tobacco use, diet, physical activity, but that only constitutes 30% of our health. The other 70% is physical environment, socioeconomic factors, and healthcare. But again, we focus on the 30%. We're really good with that, right? We like that, right? That's easy. That's very palpable for us. It's digestible. We can wrap our heads around that. But these other issues are far more difficult issues to address. But they really require our attention, because this is what's really driving inequities in this country, but also globally: healthcare, socioeconomic factors, and physical environment. Such that all of that really does impact, racism impacts the health of people. We've not talked about it, we've not thought a lot about it, but that this whole system of racism, which is a system of structuring opportunity and assigning value based on some social construct of race that unfairly advantages some, it unfairly disadvantages, but it also unfairly advantages people simply based on a phenotype, right? That's all it is. It was just a few years ago, maybe 10, 15 years ago, when I really began to understand that racism was a social construct. in my formal education and undergrad and graduate school, we really didn't, we kind of talked about race as being fixed. We focused on the more biological nature of racism, of race. And we made it, as far as I was concerned, we made it this biologic issue, when actually it's all about how we define race in America, but globally, such that if we were in Brazil, Brazil has over 100 different races, right? Again, it is a social construct. So what can we do? So these are the new slides that I added because I wanted to really kind of like drive this point home and talk about the work of CCPH. And that is that one of the things that we did 3 years ago is we developed what we call Introduction to Structural Racism training, where we are offering this training to public health leaders, students, and others. 2 years ago, when we last had our convening in person, we were in New Orleans, and we partnered with the Ashe Cultural Arts Center, and we did a session called Dismantling Structural Inequalities, Infusing Art in Our Work, where we actually were just kind of blown away with how we can use art as a driver to really better understand racism in our society, but also talk about it and also present it to other people, right? So what we call this work, Carol B. Bell, who is the former executive director of the Ashe Cultural Arts Center, talks about it being both head and heart, head and heart. And it requires both of them. And we've been talking a lot about it, kind of like the head part of it, right? It's very cerebral, but we have to have people, there has to be a change of heart. And so one of the ways to touch the heart, the human heart, is through the arts. And so this was an exciting opportunity for us as an organization to say to people, like, we can talk about it, but we can also sing about it. We can also have drama. We can have spoken word. It's many different ways that we can use to really help people to understand structural inequalities that can persist in our country and globally. I keep saying and globally. And so the other part of our work that we are advancing through our Introduction to Structural Racism training is that we actually take people to plantations that are in the South. This was in New Orleans, and these are images from the Whitney Plantation in Louisiana. And the Whitney Plantation is very unique. If you're in Louisiana, certainly New Orleans, you absolutely need to visit the Whitney Plantation. And we take people on these visits. When we're in North Carolina, there are 2 plantations that have been restored, and I think all southern states probably have plantations that have been restored to some degree. But what our intent in doing this is really to just kind of take people to the beast, the belly of the beast, where people are able to just think for a moment in the 3 to 4 hours that we're at these plantations about the origins of the enslavement of African people in the US. And this can be a very heart-wrenching, gut-wrenching experience. For many people outside of the South, few people are aware that plantations still exist, but it provides an opportunity with you to really visit these plantations. And again, I think about the Whitney Plantation in particular, because it really highlights not the master or the owners of the enslaved people, but it really lifts the enslaved people. There are burial grounds there. There's sacred grounds where these people lived and worked. And many of the people, the tour guides, are actually the descendants of the enslaved people. So our goal here is to not just talk about racism, but to also engage in an opportunity for people to kind of see it almost firsthand, or at least think about it in this time period where they're on this camp, on this plantation. So again, I want to talk some about the National Campaign Against Racism that we've joined with others, including Dr. Kamara Jones, that talks about the 3 types of racism: institutionalized, personally mediated, internalized racism as well. This is all, when we think about community engagement, this is the heart of engagement, right? People are spending a lot of time and even a lot of money on engagement at this moment in time through RedX Up, through all these initiatives. Foundations are pouring millions of dollars into COVID response. But it's critically important that we also name racism as a driver for the disproportionality and the inequities that we're seeing in COVID-19, both at an institutionalized level, personally mediated level, and also internalized level as well. And our strategies include, this whole campaign is naming racism. Number one, we have to name racism. Number two, we have to ask how racism is operating here. And Dean Miner talked some about that, about the work at Stanford. And I hope that this particular, this model is something that Stanford is using or should be thinking about, is again, naming racism on the campus, and then asking the critical question of how is racism operating on the campus of Stanford and in our communities? And then third, organizing against racism, right? You have to organize, you have to be intentional about it. And so I want to offer to you these concepts around strategies for organizing that Marshall Gantz at Harvard sets forth, and they are around relationships. You have to build these relationships to organize, identifying others who can work alongside of you as allies in the work of dismantling structural racism. Then the public narrative, the second point is the public narrative. We have to change the narrative about this. At the height of, last summer, when we were looking at the Black Lives Matter movement, I began to ask people, and I continue to ask them, is it a moment or is it a movement? So, we're reckoning with that now as we are, many of you are actually daily looking at the trial that's occurring in Minnesota. So it's about capturing the narrative around racism and really he who controls this narrative really drives this, and we have to control this issue, this narrative. The third thing is strategy. And the fourth element is structure. We have to be organized. And then finally, around taking action. So authentic partnerships that I mentioned earlier is about building upon identified strengths and assets and working along in those partnerships to address the needs, but also increase the capacity of all the partners. So I want to highlight this particular slide and these findings here. And Dr. Adams kind of talked about this, and others have as well. And you'll hear this, I think, some of these themes throughout your convening. And that is, these are elements that we drew from conversations that we had with patients that were working with us on a PCORI funded project about 3 years ago. And so I took the liberty of actually kind of like inserting the words communities. And the four things that we took away from that experience with them and that they shared with us is it just kind of distilled into these four elements. Patients or communities want trust. Patients or communities require evidence of trustworthiness. And we struggle with this issue of trustworthiness. What is it? Trustworthiness is the evidence that I can trust you. And I say to people that people do business with people that they trust. And in this moment of COVID-19, what we call vaccine hesitancy, it's really a lot of this, in particular within Black and Brown communities, is really based on a lack of trust in systems, even at the highest level. So the trust is not unwarranted. I mean, the mistrust that people have for these systems, or the lack of trustworthiness, is that these systems have not proven themselves to be trustworthy over time. The third point is that patients and communities want transparency, and that patients and communities want to be partners. And that's the work of Community Campus Partnerships for Health, is to advance partnerships, authentic partnerships. And with that, I'll end. Thank you very much.
Mr. Richmond, thank you so much. I also wish that you could hear a warm applause from all of our attendees. And again, you'll have to, you'll just have to do with my emoji. Can you see it now? There you go.
Yeah.
Okay, we have, thank you for a wonderful, wonderful presentation. It was a real call to action for all of us here in our communities. Started it out by saying it's not enough to notice what's bad out there in terms of health disparities, or to feel sorry that those health disparities out there, but it's really time to roll up our sleeves and work towards the health equity that we all would like to see. So we have a few questions that have been submitted here in the chat, and I'm going to let a few more of those come in, and I'm going to take the opportunity to throw out the first question. You know, both of your talks highlighted the importance of partnership and community engagement, and we've seen so much evidence of the growth of recognition and, like you said, Mr. Richmond, funding for community engagement over this last year, both due to our national racial reckoning and also, of course, the COVID-19 pandemic. I would like to throw out to both of you, what can we do to sustain this momentum and advance the work of community engagement and partnership in the research conducted here at Stanford, but also nationally? I'll let you fight over who wants to take the question first.
Passing it off.
Okay, Dr. Adams.
Sure. I mean, I think one part of what we're trying to do now is to build infrastructure, right? To create an infrastructure that can then sustain some of these activities over time. Obviously, the infrastructure requires funding, but in terms of, again, sort of creating pathways, making it a little bit easier for people to essentially do the right thing in terms of involving communities, but also to create an infrastructure that makes it that we can more easily and more readily communicate and be transparent, right? I mean, I loved Mr. Richmond's rubric in terms of that trustworthiness and transparency. All of those things require us to be open. And I think to so many people, we're a closed door. In fact, we're a closed door with like scaffolding and probably ivy and a moat, right? And so the question is, how do we get rid of all that? And part of that is building an infrastructure that really says, no, we're an open door. That'll be an open door, but we're going to come to you, right? And so facilitating that process. I think another thing I would say too is to think about how we think about research. What is good research? What's good, solid research? If the research that we're conducting has never been looked at from the lens of the people who are likely to benefit and or be harmed by it, I think we have to ask ourselves, is that good enough, right? And the more we start thinking about what we mean by high quality research and what classifies as high quality research from how we define racism, how we define race, my goodness, but at a very basic level, or gender identity, whatever it is, all the way through to how have we even considered the impact on the communities that we're trying to affect. I think that is also going to shift things quite a bit, because if people are held accountable, it'll make a difference.
No, I agree. I think that this whole idea of this kind of open door policy is critically important, Dr. Adams. I mean, I think when we look at COVID-19, the vaccine, what we call vaccine hesitancy, it's rooted in just that. Communities had no idea that research was occurring in laboratories across the US, across the world, to address this very moment. And so communities, Black and brown communities, were saying, how did you do that so fast, right? And we called it warp speed, which, you know, I'm convinced that this was a group of people who were Trekkies in a room, and they thought, this is a great title, we should call it warp speed. And I'm thinking, no, that's the wrong thing, right? Because in the minds of people, it suggests that you cut corners, right? And so I think that at Stanford and other places, we have to literally open the doors and say to people, this is the kind of research that's occurring on our campus, right? That which is not proprietary, in particular for state institutions that, you know, where people's tax dollars are going into it, and typically that's everywhere. People need to know how their dollars are being spent. They need to know about the research that's in the pipeline. And one of the examples of this that I lift up also is the Alan Alda Center for Health Communication. Several years back, I had the good fortune of meeting Alan Alda at the PCORI meeting. And I was just kind of taken back by why he was there. I was like, why is Alan Alda here? And the reason why he was there was because as a patient, but also as a person who has a stellar movie and TV career as an actor, he brought together his love and passion for the theater and drama with his passion as someone who's portrayed a physician for years on MASH to really establish this center wherein he's training scientists and researchers how to communicate their findings to the public. This is important. This will lead, I think, to enhanced and understanding and appreciation for research And so those are some examples I think that Stanford has to embrace, and other academic institutions as well.
This is so helpful. I think we have a number of our colleagues who submitted questions around this idea of trustworthiness. So I see Chiquita Tuttle, I see Leanna Gefter, I see Maria Juarez Reyes have all asked, how can we increase our trustworthiness? And both of you have given lovely analogies about tearing down scaffolding and taking off ivy and opening doors, and this idea of becoming better communicators with people outside of academia. Can you add anything to how, there's lots to add, but what would you like to add around increasing our trustworthiness in the communities where we seek to make impact?
I would say that to engage with communities when you don't need something, when you don't want something, when you don't just want them to be a research participant. I didn't say research subject, but a research participant. Forging and building authentic partnerships is essential and critical to this. Some of the challenges that we're seeing again right now in this moment are largely can be attributed to the fact that we just don't have authentic partnerships. They don't exist. And so we have to have those partnerships. And I think that right now, again, is this a moment or is this a movement? And so it can be a movement forward for academic institutions to say, look, there's a reckoning that can occur. And you can say, look, we need to fix this. We really need to build these partnerships with the community, put the money into these partnerships, support these partnerships such that when we want to connect and engage with the community around research, they're more willing to be involved in our work. For communities, it's essential. I think of it, I'm old school around Maslow's hierarchy of need. Research is not at the highest, the community is not thinking about research. The community is thinking about food. The community is thinking about how I'm going to pay my rent. Am I going to have a job next week? And in COVID-19 with essential workers, that's the most important thing. And I have seen, universities kind of make that pivot in this moment, but keep it up, right? Keep those food campaigns. One more thing, even one partner shared with me that one, I will not name the university, but they were actually looking at the fact that they had employees that they were not aware of that were food insecure. These are the people that are the backbone of academic institutions and medical institutions. And these people are making maybe minimum wage or a little bit more. They can't afford to hardly live in the same community where they're working. And so all of those things will go a long way in really building and supporting and sustaining authentic engagement.
Thank you so much, Mr. Richmond. Dr. Adams, I'm going to let you take the last word, and then I'm being told we are going to be scooted out to our breakout rooms. So please.
Sure. So actually someone asked me in the chat, what was sort of your worst experience and best experience? And I would sort of wrap it into one, which speaks directly to this trustworthiness, right? So I hear all the time from other researchers, but I mean well, I just want to help. And so I think you have to think beyond your own intention, right? And what really means is, and this is a perfect example, is I was working with First Nations communities early in my career up in Nova Scotia. And so my job was to go up, we were sharing research, we were talking about things we wanted to do together. And I walked in the room and it was this big group, and some of these people were lawyers for their people. I mean, it was a very intimidating room. And so I'm up there wanting to talk about statistics and what I want to do research wise. And someone raised their hand and they said, excuse me, but who's paying for everyone to be here today? And we said, oh, well, we have this, particular grant. So they said, but who gave you the grant? And so we sort of traced it back and said, well, it's this person, this group, and then that group. And one of the groups that gave us a grant was a Canadian government. All of the Indigenous peoples in the room stood up, put their stuff down and said, we're walking out. And they walked out. And I said, what just happened? Here I am. I want to work with you. I don't understand. Like, what happened, right? And one of them was kind enough to come back. Well, actually, we walked out and we're sort of like, can you tell us what happened? And so over coffee, they were like, just to chat, we can have a conversation. Turns out that their concern was that the Canadian government, because they were partially funding this one little presentation or talk, would then say that that counted as consultation with the First Nations peoples, and therefore they did not have to consult with them on other important matters because they could check that box off. They did their consultation that month, right? I had no idea. And I certainly wasn't going in thinking I'm trying to do anybody harm. I'm thinking I'm all about, sort of working together and being open. But that was like the worst experience of my life, to have a group walk out on me. And it was the best. It was the best because it reminded me, check yourself. You may think you know a lot, but you don't understand where these communities are coming from until you talk to them and understand their complexities and the power dynamics they're dealing with. And you have to be a part of the solution, not part of the problem. And unless you know those things, you can very easily become a part of the problem and not even realizing it, and become part of that untrustworthy group. And so I would just sort of say, do your homework, talk to people, understand where they're coming from, and understand that it's not personal about your own trustworthiness. It's about understanding the context and being able to be a true partner and understand where they're coming from so you can work with them to do good. So that's all I would say.
I can't imagine a better ending to this keynote. I want to thank both of you so much, and we really appreciate it. And now we're going to go into our breakout rooms. Davis and Charbel, are you going to introduce it?
Yes. Thank you so much again, Dr. Elise Adams and Mr. Al Richmond, for sharing your wisdom and your experiences with us. I know that I personally learned a lot, and I'm sure that all of our attendees would also agree. So now we're going to transition to the breakout session portion of the symposium.
Yes, thank you so much, both of you. That was really wonderful. So as mentioned previously, there will be 3 breakout sessions featuring faculty leaders and community partners who will be sharing more about their community work. And each breakout room will consist of a panel discussion followed by 10 minutes of Q&A from attendees. So for the first breakout, in the first breakout room, we will focus on COVID and health equity. So you will hear from Dr. Anisha Patel and her community partners, Cecilia Castro and Genova Islas from the Dolores Huerta Foundation and Cultiva la Salud, respectively, who will talk about their work fostering community economic partnerships to address food insecurity in California's San Joaquin Valley. You will also be hearing from Professor Daniel Ho, Derek Ouyang, and the community partner, Dr. Analilia Garcia from the Santa Clara County Public Health Department, who will talk to us about the Santa Clara Stanford Partnership for Community-Based COVID-19 Response.
In the second breakout room, they will be discussing climate change. So you'll be hearing from Dr. Kari Nadeau and her community partner, Violet Sena from Climate Resilient Communities, who will share insights about understanding climate change and health in vulnerable populations in the Central Valley. You'll also hear from Professor Gabrielle Wong-Parodi, who has also collaborated with the Climate Resilient Communities to advance the Community Bay Initiative, which is a collaboration committed to understanding and mitigating impacts of various climate-related hazards and disruptions on economically disadvantaged communities in the Bay Area.
And the third breakout room will center around racial equity. So Dr. Italo Brown and Professor Katie Brown Johnson will be talking to us about Presence for Racial Justice Partner Clinics, which is an initiative that implements strategies to promote anti-racist dialogue among clinicians, along with actions to foster better connection and practice with Black patients during virtual visits. So please go ahead and choose a breakout room to attend using the breakout room button at the bottom of your screen, and feel free to hop between breakout rooms during this session. And just a gentle reminder that we will be regrouping at 5:10 p.m. for a closing address by Dr. Bonnie Maldonado, who will talk to us about the vaccination efforts in the community and the path forward. Enjoy. I think we have everyone. So welcome back from the breakout sessions, everyone. We hope that you have had an opportunity to delve deeper into some pressing issues and were inspired by some of the incredible ongoing work between Stanford and our valuable community partners.
So now we would like to introduce Dr. Amy Liu, Associate Chief Quality Officer and Vice Chair of Quality, Safety, and Improvement at Stanford Healthcare, Clinical Associate Professor, and Chair of the Health Equity Committee at the Stanford Medicine Center for Improvement. Dr. Liu will introduce Dr. Bonnie Maldonado, who will provide some closing remarks.
Wonderful, Davis. Thank you so much. This is such a honor to be a part of this symposium and to be able to introduce Dr. Bonnie Maldonado. Dr. Maldonado is the professor in chief of the Division of Infectious Diseases, Department of Pediatrics at Stanford here. She's also the Senior Associate Dean for Faculty Development and Diversity at our school. Dr. Maldonado attended Stanford for medical school, then was a pediatric resident and a fellow in peds infectious diseases at Johns Hopkins. And then Dr. Maldonado served in the Public Health Service and the Epidemiology Intelligence Service for the CDC, where she was awarded the Alexander Langmuir Prize that was named in honor of the founder of the EIS program. We know that Dr. Maldonado has led a number of NIH, CDC, USAID, Gates Foundation, and WHO-funded domestic and international pediatric vaccine studies, as well as studies in the prevention and treatment of perinatal HIV infection in a multitude of countries, including US, India, Mexico, and Africa. I think we have all seen the extraordinary leadership and the support from Dr. Maldonado during the COVID pandemic for all of us here in the Stanford community. And with the onset of the pandemic, Dr. Maldonado has over 10 clinical epidemiology and laboratory-based studies in this area, is involved in epidemiological modeling for this at the university, state, and national level. She's the chair of the American Academy of the Pediatrics Committee on Infectious Diseases, is a member of a number of different organizations and societies in this space as well. Dr. Maldonado is also a member of the board of the Pediatric Infectious Diseases Society and a liaison to the the Public Health Service Advisory Committee on Immunization Practices. Finally, Dr. Maldonado has published over 200 peer-reviewed articles in scientific journals and is a co-editor of 2 seminal pediatric textbooks as well. I think we have all benefited in so many unspoken and ways from her presence and her leadership and her support in all aspects of diversity, inclusion, equity, and community engagement. It is, again, my extreme honor to be able to introduce Dr. Maldonado for the closing remarks. Thank you.
Thank you so much, Amy, and thanks to all of you for being here today. I really want to thank you all for participating and engaging, especially in the breakout sessions. I want to give special thanks to all of our speakers, especially Dean Minor, Dr. Elise Adams, who was able to really pivot and be a full-fledged member of our faculty, given that she's only been on board for a few weeks, and Mr. Al Richmond, who provided wonderful commentary around the issue of community engagement. I'd also like to thank all of our presenters and moderators in the breakout sessions, including that on health equity and COVID-19, climate change, and racial equity. I also wanted to take a moment to thank all of our sponsors, the Office of Community Engagement, our Office of Faculty Development and Diversity, my team members who really have worked hard as well to help with this event, the Department of Emergency Medicine, the Division of Primary Care and Population Health, the Office of Diversity in Medical Education, the Stanford Precision Health for Ethnic and Racial Equity Group, the Center for Asian Health Research Education, the Stanford Haas Center for Public Service, the Stanford Center for Innovation and Global Health, the Stanford Healthcare Inclusion, Diversity, and Health Equity Group, and the Stanford Medicine Center for Population Health Sciences. And in particular, I'd like to thank the Planning Committee for today's symposium. In particular, Glenda Estioquio and Jill Evans, who made sure everything occurred well and that was looked efficient and seamless. Also, the Office of Community Engagement lead, Dr. Lisa Goldman Rosas, for her remarkable leadership and thoughtfulness, and our Office of Faculty Development and Diversity lead, Dr. Magali Faziotto, who really helps me get through every single day and who has helped me get through every day of this pandemic. And so let me just make a couple of comments. I also want to thank our student leaders, Charbel Bukhalil and Davis Cho, who have really done a great job here. But before I turn it over to them, I just wanted to spend a few minutes to talk a bit about some of the work that I think we can take away from this event. How do we engage communities in health equity research? I really want to make this a call to action for all of us. And I think we are all engaged today and really have been refueled around this area, given the remarkable speakers and topics that we've heard. And so really our current context, as we know, given all of the events that have happened in the past year and before that as well, is the issue of social justice. As leaders in academic healthcare, we really need to recognize, and I do think we are starting to recognize, that diversity and inclusion are core to our success and our excellence in patient care research and education. And it's an opportunity for us to take advantage of this awareness among all of our constituents, and not to forget that this is really an important issue, an important mission as academic leaders and in our communities as we engage with them. Just as looking at the current context around COVID alone, as you've heard already, for those of you who went to that breakout session, we know that with over 3.5 million cases of COVID-19 now reported in the US, and several thousand deaths that we've seen in the US as well, we know that we are missing a lot of data on race and ethnicity. And how do we capture that data when we see that even the data that we do have, as you can see in the table on the right, demonstrates that there is overrepresentation of some of our racial and ethnic groups in terms of the percent of COVID deaths and percent of COVID cases relative to their population representation. So why are we missing some of these other racial and ethnic groups? There are numerous reasons for that, and we really need to try to engage our communities to understand what is going on in their communities and help them. Now, what other issues that we need to deal with are distrust in the medical establishment. We know that there are historically rooted distrust issues with the medical establishment, well-deserved. We can only look back at the issue around HeLa cells and what happened to Henrietta Lacks around collecting these cells without her and her family's knowledge. And the US having a long history of forcibly imposing ethically questionable or ethically inappropriate actions, such as sterilizing people of color. So we know that Black and Latinx individuals also suffer institutional oppression, as we heard before from our earlier speakers, representing 30% of the US population, but only 6% of participants in federally funded clinical trials. So we know that there's more that we can do. What do we do and how do we understand these contexts? Well, first of all, we have to understand in very granular terms what social determinants of health are and what they are doing, not only to COVID-19, but to all other health conditions that affect our communities of color in disproportionate numbers. So understanding that poverty, frontline jobs, crowded living spaces, reliance on public transportation, the presence of food deserts or swamps, and inadequate insurance coverage really affect our populations. And knowing that the majority of people who don't understand what these even mean, what these words even mean, including in our communities of color, and what those impacts are in our populations, we really need to dig deep and define these terms. Make sure people understand what they mean, and that the fact is, as you heard earlier, that these social determinants are really affecting very granular and real problems, such as limited job and economic security, jobs with lack of adequate resources, for example, PPE, and social distancing, which are critical in this COVID time. And in the longer term, no access to healthy food or self-rationing of healthcare. So breaking those issues down and understanding how we can engage our communities and getting that word out to them, as well as to the people who are in leadership, so that we can do the right scholarly trials and engagement and understand how we can break down these social determinants to make them more equitable. I want to talk just a bit about the CDC's, the Centers for Disease Control Social Vulnerability Index, which has been around now for some time, and which is really a census tract based approach to understanding how vulnerable our populations can be to a variety of immediate and chronic conditions. And you can see there on the left, there is a breakdown of social vulnerability indexes with over 15 factors that can be used to determine a census tract's of vulnerability. And you see the darker colors are high vulnerability and the lighter colors are low. And you can see if you overlay that map with COVID-19 cases, they match very well. We can use this kind of determinant to understand what other vulnerabilities our populations are at risk for, and then try to address what are those vulnerabilities and how can we reverse them. So the answers are out there. We need to search for funding and for ways to engage our communities to do the important work to reverse these trends. And how do we reach our marginalized populations? Well, you heard a lot about that today. We have to use our existing community engagement structures, our local trusted leaders, our community and faith-based organizations, community groups, and health centers. But we can also use newly developed engagement structures, that is reaching out to new communities. We need to disseminate transparent and comprehensive information in a culturally appropriate way, for example, about the vaccine, the COVID vaccines, in multiple languages and in accessible ways. This is a real example of how we need to even the playing field for equity, for example, for COVID vaccine, as we want to do for other diseases and other health conditions. So, for example, Stanford Medicine has a good track record, I would say, in fact, an outstanding track record of COVID-19 engagement efforts, with just a small sample here, looking at some of these studies that we have been funded to do through epidemiology, population health, and other fields. And in fact, we have over 400 studies throughout the university around COVID. Why can't we continue to do studies with our communities for other diseases, chronic diseases, diseases and conditions that enhance the risks of poor social determinants of health? So this is a way that we can move forward. So my call to action is to sustain efforts to promote health equity and diversity in the healthcare workforce. That is the academic call, and that is the way that we can partner with our communities and engage with them in a scholarly collaboration. So fostering research in health equity can bring results directly back to our community. With that in mind, we are currently putting together a health equity action leadership network. And you can see just a few members there of our leadership team that we have recruited to help us develop scholarship and disseminate resources and funding opportunities and foster collaborations around health equity and community engagement. One example is our Stanford Precision Health for Ethnic and Racial Equity program, which was funded from the NIMHD at the NIH 5 years ago, and we are continuing to do work with Radix up there, and as well with CEL, the CEL program that you heard earlier. So we are involved in some of these large-scale programs, and we need to do more. Finally, we need to engage our young trainees and our young scholars. And one of the ways we're doing that now is by providing pilot grants for some of our scholars to start developing their own scholarly approaches to health disparities research, and especially with community engagement. You can see a few of our colleagues here who have engaged with some of the COVID-19 work that we started in the last year. So I'd like to close again by thanking all of you for being engaged in our session today. It was really exciting to see all of you here. We think that health equity and community engagement go hand in hand, and they are essential partners. And I want to hand it back now to Charbel and to Davis for the next steps and to close out this wonderful afternoon. Thank you so much.
Thank you so much, Dr. Maldonado, for those really amazing closing remarks. And thank you again to all of our speakers today. I feel really re-energized personally through all of these different talks and hearing how we can better work with community to work towards health equity. So this concludes our event for today. Thank you everyone for joining us and participating in the symposium. We're really in awe of all of your community engaged work, and we really look forward to strengthening these partnerships going forward.
Absolutely, I agree with Davis. And just a reminder that the poster presentations are pre-recorded and available for you to watch on the symposium website. And just in order to keep improving this event in the future, we would love to hear your feedback about what you enjoyed and what we can do better in the future. You can find a brief survey in the chat. Please take just a minute to fill it out, and with any feedback you may have. Yep. Thank you, everyone, and we hope you have a great evening.